Now I think may I call Dr. Gajendra Chawla sir to make his presentation, case-based scenario. I will make a video of yours. उस पे जाना है.
Can I start? Malay sir, can I start? Ji sir, we'll do that. First we'll finish with this IC and then probably we'll talk about in the future what we should do. So thank Dr. Malay for giving the opportunity. As you know that because of the change in the lifestyle, food habits, the number of diabetic patients are increasing, and so the patient with the diabetic retinopathy and maculopathy. DME is a multifactorial disease, and so the treating DME always remains challenge to the retina specialist. Since ETRS studies, focal and grid laser has been the mainstay of the treatment, but with the recent advances in the about 2 decades like OCT and intravitreal pharmacotherapy that has changed the management of DME, and now we retina specialists are aiming for the vision improvement rather than the prevention of the vision loss. So DME can be classified as a non-central, central and tractional macular edema. And there are various treatment options are available, like ranging right from the metabolic control, the laser, intravitreal pharmacotherapy, and combination of the various treatment. There are several randomized control trial has been available in the literature to evaluate the retinal laser, intravitreal, anti-VEGF and steroid treatment, and a guideline has been published in the literature right from the American guideline, European guideline, and the Indian treatment guideline, about which Dr. Malay was also referring to. I will be sharing few of my case depend on guideline how do we treat and what should be the treatment protocol for the various patients. This is the first case of a diabetic retinopathy having the poor vision with the poor glycemic and systemic control. The HbA1c was 9.7. He was presented with this scenario. There was a hard exudates and there was a CSME. Vision was compromised. We have asked for a this was the angiography shows the confirming the finding. OCT also shows the hard exudate beneath the macula, and there was a CSME not very significant. CMT was not very increased in the right eye, but left eye was bit better, bit more. We have advised for the strict metabolic control and kept patient under observation. We have discussed the pros and cons about the. We have advised the anti-VEGF, but patient was because of some reasons was not ready for that at particular time. But then we kept on the metabolic control. After 4 months, when he came to us, his vision was improving, and the systemic control with the only that exudate was decreasing. And he had a good vision even after the 4 months of strict metabolic control. Sometimes it may take little longer period to resolve this macular hard exudates and macular edema. Another patient having with the only strict metabolic control, the diabetic maculopathy has been improved within 9 months. There are certain clinical situations. There is one clinical situation is non-central macular edema with a good functional vision. Here again the first criteria we always keep is a good control of systemic conditions, and focal laser was advised, which was done, and within 6 months the result is good. Another patient with which undergone the laser therapy, and just within 5-6 months that CSME has been improved. There is another clinical situation when central involved macular edema with good visual function. If vision is good, 6-9 are better, and if patient is asymptomatic, one can observe with the close follow-up, and with the good metabolic control, it should be advised every time. When in follow-up if there is a increase in the cystic species or there is a decrease in the vision, one can start the anti-VEGF therapy. This is one case of 50-year-old male had a diabetic and had a IHD. He underwent PRP elsewhere and vision was good. This was the angiogram there, that showed the residual NV and CSME. This patient, because there is a OCT shows the CI macular edema, but vision was good, so we decided to just do a fill-in PRP for NVE, and the kept patient under follow-up. He is under follow-up since last more than 1.5 years, like from November 21 to last follow-up last week. He is still maintaining good vision without any anti-VEGF injections. But if vision is compromised, certainly we have to go for a treatment, and anti-VEGF is a good choice or a first line of treatment, especially in the phakic eye, because of the risk of IOP and cataract formation with the dexamethasone steroid implants. There are a number of VEGF is available. The options are available with us. How many injections? It is again various studies suggested the loading monthly injection with anti-VEGF followed by PNR or treat and extend protocols. One patient of 53-year-old female with a poorly controlled diabetic, she is also underwent PRP. Her vision was 6, 12 and 8 and having a grade 1 nuclear sclerosis. The angiogram shows residual NVE, minimal CSME, laser and there was a laser mass. OCT was showing no macular edema, so we did complete the PRP. But when she came for follow-up after 3 months, there was a CSME and central thickness increased, so we have given anti-VEGF, Resumab, 2 injection was given, and the patient was, the situation was improved, and she is maintaining good vision and good OCT. Another patient with severe NPDR with CSME. This patient was given aflibercept in August, and the second dose was given in October, just after 1.5 months. And patient has received 4 injections, but there was no improvement in CME. There he was CSME was cystic spaces was persisting. I don't have that. I missed that one angiogram of February where the cystic spaces was increased. So we have given the we have given Paginex, and after that, that patient has improved. Another patient of having a poor vision with a good cystic spaces has received 3 eccentric injection with the condition has improved and the patient is maintaining good vision. This is another patient which has received recurrence DME. He has received multiple ranibizumab initially. Now he is on intravitreal aflibercept on PRR basis. You can see that in August we have there was a cystic spaces. We have given injection. He was improved. Again reappear in February 22 with another injection has improved again. Again in August 22 there was a recurrence of cystic spaces macular edema, and we have given another injection. The intravitreal steroids is again there are evidence suggested that the inflammation in addition to VEGF plays an important role in the DME, but because of the risk of raised IOP and early cataract formation, it is used in the recalcitrant cases. This one case, that lady I have shared earlier, the other eye of that lady with the poor glycemic control. She has also undergone the PRP in this eye. This is the FFA shows the pre-retinal hemorrhage, diffuse edema. But on OCT there was a very minimal spaces here. So we have decided only to go for a laser in March 22. We have completed the laser and she was under follow-up. And in August, when she came after 5 months of our laser, there was an increase in cystic spaces and there was a early neurosensory detachment. We had given the anti-VEGF Resumab. There she has received 3 doses, but she was not improving her cystic spaces. That CME was persisting, so we decided to go for a Ozurdex because this eye was a pseudophakic. So we have a plan for Ozurdex, which was given in the January 23. After 3 months, when she came for follow-up, her situation was improving. There is another patient who has received Ozurdex. The CSME has decreased. This is one 25-year female. Unfortunately, she was diagnosed just diabetic in 2 years back and was having a retinopathy. She underwent PRP elsewhere, and when she came to us, she was having a PDR with TRD. OCT in right eye shows the gross CME, but with the extra foveal traction. Since the fovea was not involved, so we have waited for, we have decided we can try with Ozudrex, because there were some issues with the anti-VEGF because of some systemic this thing. So we have decided for the Ozudrex. And see, this patient we have given in June 2018. After 1 month, there was a CME after this 1 month post Ozudrex, and gradually, if you see, after say about 6 months, her condition was improving, because her condition of systemic condition was also improving. There was mild hemorrhage here and there, but still that central fovea is good, and she was maintaining good 6/18, 6/12 vision. Triamcinolone is another option for the as a steroid. We can give anti-VEGF, although the most of the guidelines, including the Indian treatment guidelines, they are silent on use of intravitreal triamcinolone. But in our scenario, because of the patient comes from the low socioeconomic status, we are using triamcinolone 2 milligram, not the 4 milligram which was earlier used in the various studies. And we are combining with the laser once CMT is decreased. There is a raised IOP was observed in 12 to 14% patient, which was controlled with the topical anti-glaucoma therapy, and the surgical treatment was required only in the 2% of the cases. This is the one patient we have initially asked for the systemic control. The hard exudate was gone in 7-8 months, but there was a still macular edema was there. So we decided to go for IVTA, and after 1 month of IVTA, patient was improving, and this is after 6 months of IVTA, the vision improved to 6/12 in 10. In spite of so many options we are having, so many trial and error we are using, but there are certain patients, they don't respond much, and it's very difficult, they are challenging. This particular patient is under my follow-up since last almost 7 years, and he has received more than 25 procedures, including eccentric, laser, ILA, Ozudrex, whatnot. And in the last this thing, November 21, from here we have started on Paginex. Although at that time it was not approved for DME, which is now approved, but since he was because 7 years he was become my friend, so I had discussed with him all pros and cons and given the Paginex, and now he is on PRN Paginex. Every 4 months, 5 months we have to repeat the injection. There is last situation where we should talk about the macular edema with the traction. Vitreous surgery is the only choice, and this is one patient which had a CME which was increased. We have given in multiple injection. The hard exudate with the systemic control was decreasing, but that macular edema cystic spaces was persisting. In due course of the time, patient developed vitreous hemorrhage, and ERM we decided to go for a vitreous surgery, and that after the vitreous surgery the things has been stabilized. Another patient post laser, not much of clinically significant macular edema on clinical picture, but vision was not improving. When OCT showed there is a tractional element, and we after the surgery has been stabilized. To conclude, the better understanding of the pathogenesis, newer imaging technique, and the number of options available to treat improvement of vision is possible in the patient with DME. A strict control of diabetes and other systemic condition is very important. Early diagnosis and prompt treatment is the key. Non-central involved DME, laser is the treatment of choice. Anti-VEGF has established as the first type treatment, and intravitreal steroid can be considered as the first line therapy in pseudophakic eye or vitrectomy eyes. In presence of VMT, vitrectomy has to be done. Thank you so much for the patient sharing.
Sir, Chawla sir, where would you use laser in macular edema?
Sir, if you ask me, I think Vinita is going to talk about this particular subject. Yes, it's extrafoveal, definitely it is there. If you ask me, in my practice, because and I should say because my patient group is not very highly paid, except this 1 or 2 what I have shown in multiple injection, because he was having the reimbursement facilities, so probably he is tolerating all the expenses. I give a loading dose if there is a central involved macular edema and poor vision. Once CMT decrease, I do a laser.
Great.
I do a laser in my all cases.
Great, great.
Although the literature is very controversial and doubtful and very debatable.
See, what is important is that we should have our own point of view.
Yes, sir. Yes, sir.
So basically metabolic control is very, very important, and in the past perhaps when the days of intravitreal injections were not there, all the specialists used to say that one must do a metabolic control for at least 3 to 6 months, then embark upon the injections. And it's not a acute process, diabetic maculopathy. And if we control all these things, these edemas, they subside. The heart exudates, as Dr. Saab has shown, many of them have gone after good control. So that is also very essential. And as he has rightly said that all cases in Indian scenario, I am working in a government setup. I have been doing laser photocoagulation for almost now 30 years. I find that supposing in 100 patients, I hardly find patients coming back for injection in time. They would come after 6 weeks or maybe 3 months कि सर वो एक इंजेक्शन लगाया था, अब फिर हमें कम दिखने लगा तो अब लगवा दीजिए. So that problem is there. Secondly, our physicians, they don't have a direct. You mentioned that there should optometrists, physicians, clinicians, and everybody should see the fundus. Our physicians, in good old days, our Professor Mittal used to do fundus examination himself in all cases of hypertension and diabetic retinopathy. But today nobody does. And they are hardly bothered about eyes. So it's very important point that they should be told, they should be taught, and education should be proper so that they also see the fundus, and when they should refer, that is important. Many a time they are not bothered. If the vision is good, they would not refer. Even if there is PDR and macular edema is not there. So artificial intelligence is very good, as you have already mentioned, but facilities don't exist in our country. So we have to train our residents, the physicians and the ophthalmologists also for examining the fundus. That is very, very important.
So young retina surgeon is sitting. अपना नाम बताइए और अपना opinion बताइए. How are you treating diabetic retinopathy in your scenario?
Sir, I'm Dr. Pranav.
Yeah, Pranav, yeah.
Yes, sir. Actually, sir, it's almost similar to what sir said, but we don't laser usually, especially in Chitrakoot. We wait for at least 6 months. We prefer shifting to Ozurdex, but again, the same problem is that most of the patients are not affording. So that is a big problem in our scenario also. But if we counsel the patient correctly, most of them somehow get the injection done. And if we counsel them that Ozurdex works for around 3 to 6 months, and it will cost almost similar to other drugs. So in that cases also, like lots of patients take the injection, and we've seen very good results. Most of the patients presenting to us are already either proliferative diabetic retinopathy patients, and either they have hyperreflective foci and EZ loss. So we can go directly for Ozurdex also in these cases, or IVTA. If the patient is, even if he is phakic, we prefer going for Ozurdex because we've seen that most of the patients don't develop cataract soon. But IVTA in all the pseudophakic eyes, we can go for that. And otherwise, anti-VEGF is for the patients who freshly come to us. Focal and grid laser, we don't do in Chitrakoot. Very rare in very recalcitrant macular edema cases. Only in those cases we go for that.
So what do? You keep calling the same patient again
Yes,
and again,
sir.
and
Yes.
keep injecting? How long?
Mostly, sir. We wait for around 6 to 12 months at least. If it's not, most of them resolve by itself. If they are not, then we can go for focal grid laser after doing a FFA.
What is your take, Dr. Vijay? You can use the mic there.
So I have a different kind of thought process regarding the approach of DR. So for me, I like sort of a mixed approach. Like if there is some edema, I'll definitely see the metabolic control. That is very important, as sir said. But yes, if there is edema, I'd like to inject. But after like 2 weeks of injection, I will definitely go for a laser. If the stage is PDR or PDR with HRC, I'll go for a very tight laser PRP so that the thing does not recur. But it can still recur. And if it recurs, then we need to move on to a surgical option. But yes, according to me, I have seen in many cases in which I have lasered with very poor eyes, they became stable. More than that, in such eyes who had NVE, NVIs, those patients improved after a very tight PRP and a very good PRP. But yes, injections have a role, and we keep on injecting also. We keep on adding laser PRP also. It's not necessary that we'll do just 3 sittings. We can do 5 sittings, 6 sittings, 7 sittings. So it is a very variable thing to say and to comment upon. Every DR patient is different. Even a single patient with DR in 2 different eyes will have a different treatment.